Welcome. In this session, we are going to discuss about congenital orbital anomalies. Anophthalmia is defined as absence of ocular tissues, and there are three types of anophthalmia. In primary anophthalmia, there is a failure of the primary optic vesicle to grow out from the cerebral vesicle during embryonic development, and this is rare and is usually bilateral. Consecutive anophthalmia is defined as degeneration of the primary optic vesicle after its development, and secondary anophthalmia is a failure of the anterior neural tube to develop. And since neural tube is involved here, secondary anophthalmia is associated with lethal neurologic abnormalities. Microphthalmia is defined as axial length of the globe less than 2 standard deviations from the mean for the age, and it can occur as part of several genetic syndromes. Microphthalmia can occur with an orbital cyst, and this occurs due to failure of the choroidal fissure to close. This is usually unilateral, with the cyst lying in the inferior orbit corresponding to the position of the choroidal fissure, and microphthalmia with orbital cyst presents with a swelling of the lower eyelid and or a bluish subconjunctival mass. More posteriorly located cyst may cause proptosis of the microphthalmic globe. So this picture shows how a microphthalmia with orbital cyst usually presents. But in this case, the cyst is not due to a failure of the choroidal fissure to close, but is a teratoma, which we will be describing later in this session. So on CT scan, a microphthalmia with orbital cyst shows a thin-walled cyst with radiolucent center without contrast enhancement in contact with a microphthalmic globe, because it is derived from a failed choroidal fissure and an enlarged orbit. MRI scan shows hypointensity in T1 and hyperintensity in T2 of the contents of the cyst, but no contrast enhancement. Histopathological examination shows the cyst wall to be continuous with the sclera of a microphthalmic globe, and the interior of the cyst is lined with disorganized retinal and choroidal tissues. Anophthalmia and microphthalmia have poor visual prognosis and is associated with hypoplasia of the orbital bones and adnexy, because during growth of the child, orbital bones and adnexy grow along with the growth of a normal eyeball. Treatment is directed towards maintaining or regaining symmetry between the two orbits. An early institution of treatment is indicated, and to maintain the shape of the orbit, conformers of progressively larger size are inserted into the orbit until a final prosthesis is done. Instead of conformers, dermis fat graft can be used, and an advantage of dermis fat graft is that it tends to grow with the child. Corrective surgery can be employed in older children and adults with a hypoplastic orbit, and enucleation of a microphthalmic eye is usually not done if a cosmetically acceptable prosthesis can be inserted. For microphthalmia with cyst, the cyst can be retained till orbital bone growth reaches adult size, and then a corrective cosmetic surgery can be done. Branchial arch syndrome occurs due to disruption in the development of the first and second branchial arches. And among branchial arch syndromes, we have oculo-auriculovertebral syndromes, also called OAVS, and among them we have hemifacial microsomia and Goldenhar syndrome. Hemifacial microsomia can occur alone, and it is the mildest form of OAVS, or hemifacial microsomia can occur as part of Goldenhar syndrome. The other branchial arch syndrome is Treacher Collins syndrome. Goldenhar syndrome is mostly sporadic and can be bilateral. And features of Goldenhar syndrome include hemifacial microsomia, as we can see here. Limbal dermoids and lateral canthal dermolipomas can occur, and limbal dermoids can induce astigmatism, causing anisometropic amblyopia. Upper eyelid coloboma can occur. Hypoplastic ear and ear tags, as seen in this picture, are part of Goldenhar syndrome. Other components of Goldenhar syndrome are microphthalmia, iris coloboma, vertebral anomalies such as hemivertebra and vertebral hypoplasia, and there is an association between Goldenhar syndrome and Duane syndrome. Treacher Collins syndrome is also called mandibulofacial dysostosis and is usually an autosomal dominant genetic defect and is thus bilateral in presentation. And patients with Treacher Collins syndrome characteristically have depressed lateral orbital rims with palpebral fissures slanting downwards laterally. There is lateral and inferolateral displacement of the lower eyelids called pseudocoloboma, and there can actually be a coloboma in the outer third of the lower eyelid. So lid colobomas of Goldenhar syndrome is in the upper eyelid and lid colobomas of Treacher Collins syndrome is in the lower eyelid. There can be absence of meibomian glands and cilia in the lower eyelid, and Treacher Collins syndrome also has hypoplastic maxilla and mandible along with ear and hearing abnormalities. Meningocele, encephalocele and meningoencephalocele arises from congenital bony defects in the skull with herniation of intracranial contents, which can be meninges, in which case it is called meningocele, brain tissue, in which case it is called an encephalocele, or both brain and meninges, in which case it is called a meningoencephalocele. Meningoencephaloceles characteristically show pulsation of the mass from transmitted intracranial pulse pressure. Meningoencephaloceles are more common in the anterior orbit and usually presents as a mass in the superomedial orbit. It can be misdiagnosed as a dacryocele or a swelling of the lacrimal sac, and one clue to differentiate between them is that if the swelling lies above the medial canthal tendon, it is a meningocele, and if it lies below the medial canthal tendon, it is a dacryocele. Anterior orbital meningoencephaloceles can cause inferolateral displacement of the globe because they lie in the superomedial orbit, and typically in addition to pulsation they also show increase in size with Valsalva maneuver. Meningoencephaloceles in the posterior orbit are less common and they present with a forward and often downward protrusion of the eye. And as mentioned, they show pulsation of the globe which they displace forward. Morning glory optic disc anomaly has been associated with meningoencephaloceles. In Pierre Robin sequence, we get micrognathia, glossoptosis and cleft palate. And Pierre Robin sequence has ophthalmological implications because it can be associated with Stickler syndrome, in which patients have high myopia with retinal detachment. In fetal alcohol syndrome, patients have short palpebral aperture with telecanthus, epicanthus and ptosis. Microphthalmia can also be present along with optic nerve hypoplasia. Now there are also disorders of bone overgrowth which can cause stenosis of optic canal and optic nerve dysfunction. In craniosynostosis, there is premature closure of the cranial sutures, resulting in abnormal shape of the skull. In brachycephaly, there is horizontal widening of the skull due to premature closure of the coronal sutures, and it is found in Cruzon and Apert syndrome. So this is a child with Cruzon syndrome. In scaphocephaly or dolichocephaly, there is anteroposterior lengthening of the skull due to premature closure of the sagittal suture. In trigonocephaly, there is a triangular shape of the forehead due to premature closure of the metopic suture between the two frontal bones. And here the patient has hypotelorism with pseudoesotropia. In acrocephaly, which is found in Apert syndrome as shown in this picture, there is superior-inferior lengthening of the skull because of premature closure of coronal, sagittal and lambdoid sutures. In plagiocephaly, there is flattening of the occipital bone on one side and frontal bone on the other side. And plagiocephaly is usually deformational due to uterine factors, but occasionally is due to unilateral premature closure of coronal suture. Craniosynostosis is called non-syndromic when it occurs as an isolated anomaly, and it is called a syndromic one when it is associated with other abnormalities. And among the other abnormalities, syndactyly and brachydactyly are most frequent. Syndactyly is fusion, either partial or complete, between two adjacent fingers, and brachydactyly refers to short fingers. However, in Cruzon's disease, associated abnormalities are absent. Syndromic craniosynostosis are most commonly autosomal dominant genetic mutations in FGFR3 and twist genes. Ocular complications of craniosynostosis include proptosis due to reduced orbital volume, and proptosis can increase with age. Because of the proptosis, there can be corneal exposure or globe luxation, and globe luxation is a medical emergency in which there is eyelid closure behind the equator of the globe, and this occurs when there is very shallow orbits and follows either eyelid manipulation or Valsalva maneuver. It is a very painful condition and there can be ischemia of the eye, making it a medical emergency, and as early as possible it must be relieved by firm posterior pressure on the sclera between the eyelids. Craniosynostosis can also cause strabismus, and usually it is exotropia with V pattern and over elevation in adduction. Optic neuropathy can occur because of associated raised intracranial pressure or compression of the optic nerve near the orbital apex. Epiphora can occur from either nasolacrimal anomalies or poor blink and corneal abnormalities due to the proptosis. Other associated anomalies can be hypertelorism, telecanthus, and slanting of the palpebral aperture with the medial canthal lying superior to the lateral canthus. Tarsorrhaphy can help in corneal exposure and for recurrent globe luxation, and craniofacial volume expansion surgery may be required, in which case strabismus surgery is deferred and is done after craniofacial surgery is completed. Choristomas are space-occupying lesions in which the tissue elements found in these space-occupying lesions do not belong to the location in the body where the choristoma is found. And among orbital choristomas, we have dermoids, dermolipomas, teratomas, and ectopic lacrimal gland. Dermoid and epidermoid cysts are the most common orbital tumors of childhood, and these are benign congenital choristomas arising from primitive dermal or epidermal elements entrapped within embryonic closure lines. Orbital dermoids may have extensions inside the cranium, in the frontal sinus, and in the temporal fossa. The lining of a dermoid cyst is a keratinized epithelium, and the cyst contains keratin, sebum, and dermal appendages. The dermal appendages being hair follicles, sweat glands, and sebaceous glands. And it is called an epidermoid cyst when it contains only keratin and sebum and do not contain dermal appendages. If the dermoid cyst is derived from conjunctiva, the cyst has a cuboidal epithelial lining with goblet cells. Orbital dermoid cysts can be either superolateral or superomedial and can be either superficial or deep. Dermoids are more commonly found in the superolateral orbit as shown in this diagram near the frontozygomatic suture. Please see a photograph on the net because I could not find a typical non-copyrighted image of an orbital dermoid. Dermoid cysts can also occur in the superomedial orbit near the frontoethmoidal suture, and dermoid cysts of the temporal fossa can have dumbbell extensions into the orbit, and in this situation there is a characteristic pulsation of the globe with mastication. Superficial dermoids present early in childhood. So here we see the external appearance of a dermoid cyst, but this one is outside the orbit. And superficial dermoids are slowly growing mass lesions near the superolateral or superomedial orbital rim. So it can occur either near the superolateral orbital rim or near the superomedial orbital rim, the superolateral ones being more common. And dermoid cysts are palpable, smooth, non-tender lesions not attached to the overlying skin and either mobile over the underlying tissues or is attached to the underlying suture. Deep dermoids present in later childhood or in adulthood, and they are situated in the posterior orbit, usually in the superotemporal quadrant. So here we have a patient with a deep dermoid in the posterior orbit in the left eye, resulting in non-axial proptosis of the left eye. So deep dermoids present with a slowly progressive non-axial proptosis, and these are usually not palpable. Dermoids can rupture and then present with orbital inflammation, which may lead to an orbitocutaneous fistula. On imaging with a CT scan, a dermoid cyst shows an enhancing wall with a non-enhancing interior, and the contents may show a fluid-fat interface. In very long-standing dermoids detected or presenting in adulthood, there can be erosion or remodeling of the adjacent bone. Treatment is complete surgical removal of the cyst as well as its contents, preferably keeping the cyst wall intact. Complete removal reduces the chances of inflammation from residual contents of the cyst and recurrence from residual lining of the cyst. Dermoid cysts which are attached to sutures may not yield to attempts at complete removal. Early removal can prevent traumatic rupture and subsequent inflammation, and removal of already ruptured dermoid can be difficult because of adhesions. Dermolipomas are choristomas usually located in the lateral canthus in and beneath the conjunctiva, and it is very important to remember that they can have extensions into the adjacent extraocular muscle as well as the levator palpebrae superioris muscle. They can demonstrate hair follicles on their surface which can be irritating to the patient, and in this location in the lateral canthus, dermolipomas need to be differentiated from prolapsed orbital fat, prolapsed palpebral lobe of the lacrimal gland, and lymphoproliferative tumors. All of these lesions usually have onset in adulthood, but dermolipomas being choristomas are present since infancy. Dermolipomas need to be treated only for cosmetic indications, and only the superficial portion should be excised, preserving the conjunctiva and without damaging the extraocular muscles or the levator palpebrae superioris. Teratomas are choristomas having components derived from all three germ layers, ectoderm, mesoderm and endoderm, and it usually has a cystic component lined by epidermal, gastrointestinal or respiratory epithelium. It also contains tissues such as bone, cartilage, brain and choroid plexus. Orbital teratomas typically present at birth with severe unilateral proptosis and is usually associated with malformations of the globe and optic nerve. Orbital teratomas undergo malignant transformation less frequently as compared to teratomas in other sites, and treatment of orbital teratomas is excision with or without preservation of the globe as feasible. However, if a teratoma undergoes malignant transformation, exenteration of the orbit will be required. Ectopic lacrimal glands are choristomas located in the orbit, and they present with proptosis at birth. Thank you for listening.